Moving on, allow me to briefly introduce today's speakers. Dr. Ashten Duncan received his Bachelor of Science in Microbiology from the University of Oklahoma in 2016, Master of Public Health from OU-HSC Hudson College of Public Health in 2019, and Doctor of Medicine from the OU-TU School of Community Medicine in 2021. In 2024, he completed his family medicine residency training at the UNM Santa Fe Family Medicine Residency Program. And after authoring dozens of research articles, essays, op-eds, poems, short stories, monographs, and other pieces in publications like Scientific American, he recently published his first novel, Journey of the Broken Vessels. His professional interests include native health and native and tribal health, outpatient medicine, lifestyle medicine, public health, academic medicine, and applied research in primary care. And our second speaker today is Dr. Alex Lin, who hails from sunny San Diego and attended the University of California, Berkeley.
Go Bears.
For undergraduate and the University of Central Florida.
Charge on.
For medical school. He's currently in his third year of family medicine residency right here in our state capital with the University of New Mexico Santa Fe track. And when he's not counseling his patients on the benefits of plant-powered nutrition, he loves hitting the bouldering gym. With that said, Doctors Duncan and Lin, thank you very much for joining us today, and the floor is yours.
Thank you, Mario, for that great introduction. Let me go ahead and get our slides pulled up here, and we'll jump right on in. Let's see here. Get us set up. All right, everyone. Well, welcome to our talk today. So Dr. Lin and I are going to be going through an introduction of lifestyle medicine modalities and talking about how you can become certified in lifestyle medicine, either during the course of your training or after you're done training, which will apply to, I think, most of the people who are in attendance today. Just to start off, this disclosure slide actually has some stuff on it this time that's important to note. This is not a commissioned presentation from the American College of Lifestyle Medicine or any of its affiliates. This is just simply a talk that Dr. Lin and I felt very strongly about and wanted to share some information on. So we are in no way being compensated for what you're going to hear today. This is all purely for educational purposes. We're not endorsing any specific product or service. We will be talking a lot about the American College of Lifestyle Medicine and its online resources, but just know that this is because it's our official organization for lifestyle medicine. If you do want more information about lifestyle medicine after today's presentation, there's a link right here on this slide that you can go to check it out. Just want to go through a few learning objectives before we kick this off. So we've got 4 things that we're going to accomplish today. By the end of this, we're hoping that everyone will be able to define lifestyle medicine and identify its 6 pillars in the context of overall health. 2, compare and contrast lifestyle medicine modalities and with modern healthcare interventions and kind of seeing how lifestyle medicine stacks up against what we normally do in healthcare. 3, summarize the evidence showing the benefits of various lifestyle medicine practices. And then 4, we'll end it off by having everyone being able to describe the certification pathways available to physicians and other health professionals. And with that, I'm going to hand it over to Dr. Lin for this first portion.
So we will be defining lifestyle medicine and identifying those 6 pillars. So lifestyle medicine is a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions, including but not limited to cardiovascular diseases, diabetes, and obesity. Lifestyle medicine certified clinicians are trained to apply evidence-based, whole person prescriptive lifestyle change to treat and often reverse such conditions. Applying the 6 pillars of lifestyle medicine can provide effective prevention for these conditions as well. So let's dive into those 6 pillars. All right, so for our first pillar, we have whole food, plant-based nutrition. Our second pillar is regular physical activity. Third pillar, restorative sleep. Fourth, avoidance of risky substances. Fifth, positive social connection. And 6, stress management. So let's dive into those 6 pillars, starting with nutrition. While there is a wide spectrum of dietary patterns, diets that include an abundance of whole and minimally processed plant foods are preferable. Extensive scientific evidence supports the use of a whole food, predominantly plant-based eating pattern as an important strategy in the prevention of chronic disease, treatment of chronic conditions, and in intensive therapeutic doses, reversal of chronic illness. A primarily whole food, plant-based eating pattern promotes overall health by increasing the intake of minimally processed, nutrient-dense, fiber-rich, antioxidant-rich foods and beverages, and decreasing the intake of saturated and trans fats, refined carbohydrates, processed oils, added sugars, sodium, and chemical contaminants. For the treatment, reversal, and prevention of lifestyle-related chronic disease, ACLM promotes eating a variety of minimally processed vegetables, fruits, whole grains, beans, legumes, nuts, and seeds, also, aka eat food, not too much, mostly plants, as Michael Pollan so wonderfully coined. So I'm going to talk a little bit about ultra-processed food. Ultra-processed foods are industrialized. We have a little definition there that kind of makes it a little simpler. So if you can read that, if it's wrapped in plastic and it has something on the label that you wouldn't normally find in a domestic kitchen, it's almost certainly ultra-processed food. Ultra-processed foods, using the NOVA definition, is an industrial formulation made entirely or mostly from substances extracted from foods derived from food constituents, hydrogenated fats and modified starches, or synthesized in laboratories from food substrates or other organic sources, flavor enhancers, colors, and food additives used to make the product hyper-palatable. Manufacturing techniques include extrusion, molding, and pre-processing by frying. Our second pillar of lifestyle medicine is physical activity. Although any amount of physical activity is better than none, it is important that adults engage in general physical activity that offsets negative effects of a sedentary lifestyle, as well as purposeful exercise for targeted health outcomes as part of their weekly physical activity. ACLM supports the WHO recommendation of 18 to 64-year-olds performing 150 to 300 minutes of moderate intensity aerobic activity, 75 to 150 minutes of vigorous activity, or a combination of both weekly, as well as age-specific recommendations for other stages of life. ACLM supports the AC Sports Medicine, American College of Sports Medicine recommendation of adults 18 to 64 years old doing muscle strengthening activities of moderate or greater intensity that involve all major muscle groups 2 to 3 days per week. Next, we have sleep. Sleep is necessary for human life, and high-quality restorative sleep is essential for health and well-being. Unhealthy sleep is associated with most common causes of premature death and disability, and in many cases is directly responsible. The ACLM supports the American Academy of Sleep Medicine's recommendation that most adults should sleep 7 hours or more per night in alignment with their natural circadian rhythm for optimal health. The National Sleep Foundation puts upper limits on sleep for adults at 7 to 9 hours. Excessive sleep is associated with stroke and other conditions. Children require more depending on age. The chronic stress of modern society has made it more difficult to practice healthy lifestyle habits and can exacerbate health issues such as cardiovascular disease, insulin resistance, sleep deprivation, depression, anxiety, weight gain, and more. Chronic stress can cause poorer health overall, quality of life, decreased job and school performance, and lead to mental and physical health issues. Communities of color are disproportionately affected by stress caused by bias and discrimination, in addition to the social determinants or drivers of health, which are conditions in the places where people live, learn, work, and play. The ACLM recommends that individuals partner with an interdisciplinary health team to find ways to healthily manage stress. The use of tobacco, alcohol, and non-prescription medications have been shown to increase the risk of chronic diseases and death. Treatments often take time, different approaches, and many attempts. Patience and support are an important part of breaking risky substance habits. The ACLM supports the positions of the National Institute on Drug Abuse for the treatment of substance abuse and recognizes the research showing that the level of alcohol consumption that minimized harm across all health outcomes was 0. The last pillar of lifestyle medicine we will review is social connection. Research shows that having social connection is a key factor in human happiness and quality longevity. Social connection and relationships affect our physical, mental, and emotional health. People are likely to adopt the health behaviors of others in their immediate social networks, including alcohol consumption, exercise, and diet. This is why leveraging the power of social connections and social networks can help reinforce healthy behaviors. Our next learning objective is to compare and contrast lifestyle medicine modalities and modern healthcare interventions. So we have a chart here. When we look at the US, I've put a little red arrow. And so this is the avoidable deaths for 100,000 population in the US. When we look at the US, we also see that we have the most avoidable deaths of any OECD country in the world. Avoidable mortality includes deaths which are preventable and treatable. Note that large spike in 2020 for the US was related to COVID-19, a disease we know is exacerbated by preventable comorbidities, including obesity and type 2 diabetes. Next. The US also has the highest rate of healthcare spending, higher than any OECD country, which you can see by the highlight, I forgot to put the arrow. We're the top one. So despite extravagant spending in the US, our preventable and treatable mortality are also the highest. All of this spending is getting us nowhere when it comes to health outcomes. Estimated cost of chronic and mental health conditions is 4.1 trillion annually in healthcare expenditures alone. Heart disease, cancer, and diabetes are the leading drivers of the nation's annual healthcare cost. So looking at this healthy aging and prevention index, we have the US pulled up. Despite our incredibly high amount of spending, our health span is at the 61st ranking there. Health span is something that I will dive into very shortly, but you can see this disconnect between health span and lifespan. And that's something that it's a gap that we would very much like to be much shorter. We would like those last years of life to be as full as possible, as I'll dig into in a bit. All right, next. Here is a theoretical model for disease development. We start out on the left, and as we progress with time, we have points where we can detect the disease, and then we also have there on the far right where we typically intervene. The kind of example might be diabetes. We have a baseline risk where we consume a diet. Depending on that diet, it may take us with a higher amount of baseline risk. Inevitably, we do first have the first signs being elevated glucose level or a hemoglobin A1C in the pre-diabetic range. And of course, at that point, we do have pretty firm evidence that we are quite far along on the disease progression. And and only much later on do we do the typical intervention. And of course, at that point, we are talking about increased costs, as well as you can see on that far right, irreversibility has dramatically increased if we are talking about what is the conventional treatment of these diseases. Next. So a bit of a dated graphic here. Not sure why I don't keep it nicely up to date. Yeah, there's no updated. It's from 2000. So on the left, we have the things that kill people. And if I can ask my audience, these are our top killers. It's the same ones. So if we could hear that from the audience, what are our top three leading causes of death in the United States? Do we know? All right.
Stubbornness.
Not quite. We have heart disease, cancer, and stroke. All right, but on the right, we will notice the actual causes of death. So this was, so these are the non-genetic factors or modifiable behavioral risk factors, and a bit of a calculation to quantify these factors and how they contribute to death. It's a bit dated. Number one and number two have flipped. Do we have any guesses for what are the modifiable risk factors which lead to the most death?
Physical activity.
So we have a little bit of a combo, so we'll do our reveal now. It's very close. So, um, tobacco use, poor diet, physical inactivity, and alcohol consumption. So they don't add up to being all of the risk, but as we go down the list, they actually contribute the majority, more than 50%. Um, and these things are not getting better. In the 2000s, the obesity rate was about 30%. Currently, it is 42%. All righty. So what is health span and lifespan? Well, we know lifespan. In this theoretical model, we have two people. Each dot represents a year in that person's correlating with their age and their health during that year. The red person adopts a healthy lifestyle, thus for much of their life, they have some trip ups for the most part. The decline occurs far to the right. So their health, by their health metric, they were quite well until quite late in life. The person in outline with the black dots is probably more typical of what we see in America. So they had a somewhat serious illness in their 30s and never seemed to quite bounce back to where they were before. Um, and there's a slow and gradual decline. They end up having the exact same lifespan, but I think we can say for ourselves which kind of life that we would want for ourselves and what we would want for our patients as well. Um, so so for much of their life, they're living not with the functionality of their younger days. Anyways, on to the next slide. So just a question for using this kind of nice little graphic over here. Would you rather look like the person on the top or the person on the bottom? They may have the same lifespan. However, we can see that as we get a little further along from left to right, we see the person on the bottom is able to, I mean, climb a mountain later on, and we have the person on the top who has maybe had a serious hospital stay, already adopted using that cane a little bit earlier on, and so that's kind of what the basis of lifestyle medicine would like to implement. Next. Um, I have spent a good amount of my time this past 6 months exploring some different modalities, and it really has made things kind of click into place. There are a lot of different specialties and certifications, diplomates, and fellowships, which accomplish pretty much the same thing. Lifestyle medicine, preventative medicine, culinary medicine, functional medicine, naturopathic medicine, integrative medicine. They all focus on some of the foundational effects that we can have on a daily basis to our life. They largely talk about ways to change our diet, increase our physical activity, manage stress, and uh, uh, avoid substances. But they will have a different spin, and any one of them that you find you like the best. I like the simplicity of lifestyle medicine, but they're all very good, and it's a little bit it was a little bit of an eye opener just to see that they all basically are saying the same thing, and they all have had to leave the kind of conventional medicine wisdom in order to arrive at the same conclusion. Anything you'd like to add, Dr. Duncan?
No, I appreciate that foundation. So I'm gonna pick up from here, and we're gonna talk about applying a lot of what Dr. Lin just described to just show how this is played out in the literature. This is by no means going to be comprehensive. This is going to be kind of a whirlwind tour of what's out there. I highly encourage you all to consider checking out the American Journal of Lifestyle Medicine and some other publications like Preventive Medicine that actually cover a lot of these topics and a lot of these foundational concepts that Dr. Lin covered. So we'll hop right in. So we we already heard, and this figure is pretty similar to what we already had on the other slide, but the point here is just to drive it home that healthcare visits, hospitalizations, and really all healthcare costs attributable to lifestyle come out around $4 trillion. And we're talking about really the lion's share of disease in our country, since most of what we deal with in family medicine and primary care more largely come down to a condition that you can see here on the screen. And a lot of it does come from the confluence of one or more of these risky behaviors that ultimately lead to poor health. And just like Dr. Lynn mentioned, to a much, much less ideal health span overall. Now, when we start to look at where we can find evidence starting to present itself in official clinical guidelines, one that we can point to right away, anything from the ACC and AHA are really, filled with first and foremost lifestyle management. What I will pause and say here too that I think, struggle with in medicine is that a lot of guidelines will talk about healthy lifestyle, lifestyle management, yada, yada, and they don't really go into the depth of what that actually means. And so, one thing I'd like to really leave you all with is that part of what lifestyle medicine as a field has really formalized are how to use these strategies to address this. We are starting to see some more references to these resources that have been published by the American College of Lifestyle Medicine and from lifestyle medicine practitioners in the community. And that is really at the heart of what we're doing when we're managing issues, whether it's like something like ASCVD, like we see here, hypertension, prediabetes, diabetes, a lot of these things all can come together. And by using some of these modalities, we know that not only does it have a benefit for one of these conditions, but can effectively help to manage multiple, if not most of what patients are dealing with. Now, I'm going to take a step back for just a moment. I wanted to give the floor back to Dr. Lynn for just a moment to talk about this specific study here.
So my colleagues over at the Santa Fe, they will be familiar with this study. I pretty much never stop talking about it. So Kevin Hall is a senior investigator at the National Institute of Diabetes and Digestive Kidney Diseases. He performed a study, and just for a bit of context, he was a little skeptical of the idea of ultra-processed foods being some sort of thing that, would trigger worse health outcomes. How could a food, which by and large on packaging, which had statistically similar caloric intake, salt intake, fat or carbohydrate, be really all that different just because it was chemically extruded and fried in a factory? Why did that make this food any different? So he recruited 20 weight-stable adults, similarly aged. They were admitted to the NIH Clinical Center, and this is of particular note. It is very difficult to perform nutrition science, but because you can't control what people eat on a regular basis. He said, "You're not going to control what you eat. We're going to control what you eat. You're going to sit in the lab for 4 weeks." He got people to do it. Yeah. Anyways, they were randomized to receive either ultra processed or unprocessed diets for 2 weeks, immediately followed by the alternate diet for 2 weeks. So a crossover study. Meals were designed to be matched for presenting calories, energy density, macronutrients, sugar, sodium, and fiber. So packaging on the outside, they would look the same. Subjects were instructed to consume as much or as little as desired. So that's what the ad libitum means. They're just going to have at it. Energy intake was greater during the ultra-processed diet by about 500 calories a day, with an increased consumption of carbohydrates by 280 calories and fat by 230 calories. No change in protein. Weight changes were highly correlated with energy intake, with participants gaining 1 kilogram, so about 2 pounds, during the ultra-processed diet. So in 2 weeks, they gained 2 pounds, and losing 1 kilogram during the unprocessed diet. Kind of a big claim that they made in this. So they are performing a repeat with a little bit longer time trial, and it's coming. They're currently running this study right now. So if you can click forward, I have they're performing this right now. So 8 weeks there. And as you can see, we have Kevin Hall and the author of the Ultra Processed Food book, Chris Van Tulleken, also on board. And so we'll see if this actually bears out just by changing, are you picking up a hot dog versus a a chicken, how different are we talking about? Are you going to eat 500 calories more a day? Anyways,
Evan, thank you so much for sharing all that information on this specific study. And one the field of lifestyle medicine too really does encompass a lot of territory. The nutritional science piece of it has been a huge emphasis, and even when you're looking at what it takes to become certified, which we'll talk about more in a little bit, the nutritional science is a huge part of it. And I think studies like those really just help to show why it's such a huge emphasis. Now, I wanted to comment for a little bit on a growing area, because since one of our pillars is about social connections, and especially positive social connections, um, a lot of the research going on in this area is around something that, for those of you who know me, are is in the vein of positive psychology. And one thing I worked on back when I was a student back in Oklahoma was actually in synthesizing some of the evidence around these positive psychology lifestyle medicine modalities, and really kind of exploring that through the lens of a narrative review. And this is just one article. There are several that have been published since that are really helpful for those who are interested in trying to develop more of kind of a schema for approaching patient care, or approaching the interviews with patients at the point of care, to really elicit very specific information about what's going on in their lives. The one I'll point out to you was table one from the study, where we highlighted some questions that correspond to what Martin Seligman had defined under the PERMA model. So that stands for positive emotion, engagement, relationships, meaning, and accomplishments, as you can see there. This is just a way to really, as you're taking a history, as you're trying to understand about a patient's goals of care, that you can start to kind of, tease out some information that really can ultimately reveal whether they're supported enough and are capable of engaging in health behavior change, which is at the heart of a lot of chronic disease management, and a lot of what we require to really get to that point of behavioral activation, as you'll see kind of thrown around in the social sciences. So moving along to, some of the other types of evidence that we have out now, there's, a lot of really, great evidence to support that what we're talking about now with lifestyle medicine is the way to both achieve remission, kind of as we're looking at this table on the right, the remission and reversal of conditions like type 2 diabetes that most patients kind of just see as a permanent label that they will never be rid of. By the standards of modern healthcare and what we're able to offer patients, there's really nothing we can do in terms of pharmacotherapy to actually reverse diabetes. In fact, a lot of things that you can probably think of right now actually accelerate the disease process, out of necessity to keep patients safe from their current condition. But we have now some pretty clear-cut guidelines on best practices, whether it's around self-care, looking at the way people are eating meals, and going into even the physical activity recommendations that really help to lay out how we can help guide a patient along this course to potential disease remission, which is an amazing place for people to be in. I think we've all been in the room when we've had patients who've had success and been able to cut down on a few units of insulin. And this is kind of what we're talking about. Without the need for additional medications, we're pushing ahead toward getting them closer to a goal of minimal disease, if not no disease. All right, so we'll go through this through the lens of hypertension, because this is another area that there's been a lot published on, that has become just very, very granular over the past few years in terms of what we do to manage these things and what do we recommend to patients. So, I think if nothing else, you can take away from what Dr. Lynn and I are talking about. In nutrition, if you just err on the side of plant-based, whole food, diets, or at least those items that are most present in people's diets, we kind of get more into the spirit of the plant forward, emphasis. And so going back through less salt, really trying to cut out all ultra processed foods, but at least, keeping it limited, and keeping your diet close to a Mediterranean diet have all been shown to improve blood pressure control, and minimizing the need for antihypertensive agents that often can become a slippery slope as we get, closer to resistant hypertension in patients. We have heard already about the recommendations around physical activity, and we know that these have benefits for long-term management and reversal of metabolic syndrome and controlling, blood pressure longer term without the need for medications. And here are just some of the activities that have been that have been identified as being particularly helpful there. Mindfulness and breath work. So again, another area where we are seeing, this stress management piece, some of this really, getting into being able to control the response of your body, since a lot of the modern theories now really do show that, things like hypercortisolemia, chronic, overstimulation of that sympathetic nervous system are, key drivers to people just becoming, for, the lack of a better term, clamped down, and, to the point where their whole body reacts, to this chronic stress. Um, Groups where we feel comfortable and people whom we can trust, again, building these relationships. There's some thoughts, especially, kind of like in more of the modern sociology and some of the anthropology work that's come out over the past decade, that part of what might ail the United States more than anything else is really this very, very strong push toward individualism, to the point where we have people who go toward the end of life alone. And this is not something we see in other countries. And so beyond just what we eat, what we do, it's also about the people we're surrounded by. Sleep, heard enough about that. Sleep is very important and really kind of feeds back into this whole neurologic, immunologic, and endocrinologic, phenomenon that we see with chronic stress. Substances, that can really drive it. And, the most important part out of all of this is that as we've gone through all of these, you may or may not have thought to yourself, but compared to what we do in a lot of our direct healthcare services, there are no side effects to this. It is just a matter of just getting people to commit to this whole line of work, though, in order to get them to where they want to ultimately go. And so, just to highlight again, the interventions that exist across all these different pillars, our 6 pillars of lifestyle medicine, are all, of critical importance to helping patients achieve health. And, it's that salutogenesis, if you guys are familiar with that term. That's kind of what I think is really at the heart of all of this that we're talking about. All right, so we're going to move in, not spend quite as long, but to just talk about what you can do if you're sitting here today thinking, this would be something cool to explore in the future. I'd love to look into getting certified and, being able to provide more of these services to my patients. Let's talk about what that looks like. So I think most of the people in this group probably have felt this. And when I go over this, you're probably going to feel this like it's probably going to be a sharp pain that you'll feel, because it was for me. Because what we know is that lifestyle medicine training at most institutions, and definitely, it's getting a little bit better, but still really lagging behind. In most medical schools, it's not there. And so again, let's go through the really important statistics on this. About 14% of residents, so specifically resident physicians, believe that they possess the knowledge and training to provide nutrition counseling. Approximately 2 in 5 U.S. medical schools achieve the 25 hours recommended by the National Academy of Sciences. 88% of residents surveyed understand the benefits of physical activity, but here's the caveat: less than half of them felt confident in their knowledge of how to implement changes in their own lives, and then how to actually prescribe that to patients. Because what we do know is if you do it for yourself, it's easier to counsel patients on it. And then physical activity training in medical school averages 8 hours, with nearly half of the program directors feeling this to be inadequate. And I definitely have felt that before. And I went to a school where it was more emphasized, but that was more through the collaboration that the OUTU School of Community Medicine had with our College of Public Health. And if it weren't for that partnership, we would have had far less. So this is just a brief note about the American College of Lifestyle Medicine, that this is still a very new organization. that really started to see the writing on the wall, see this evidence that was coming out, and wanted to create a formal institution through which we could channel these resources, channel this understanding, and promote further investigation into how lifestyle modalities can be developed. And really, the college really does focus a lot on education and empowering everyone with the knowledge and skills needed to provide evidence-based lifestyle medicine as the first line treatment, not something that we come up with later on, not something we throw in at the end of the visit, not something that we just kind of have as an add-on, but as a primary modality for treatment. Now, the way this has been conceptualized in terms of physician training and has been extended out to other health professionals started early on with some of the early publications, one of them coming out in JAMA, and then later on being revised in the American Journal of Lifestyle Medicine. The you know the effort that's been put into trying to highlight what it takes to practice lifestyle medicine has been really robust, and we've gotten a lot farther along in terms of developing our understanding around all of this. And so when we look at how curriculum can be implemented based on these competencies and what we understand now about lifestyle medicine, there are a lot of different kind of off-the-shelf curricula that you can see. And maybe some of you actually experienced this when you were in medical school. Maybe you knew friends who had this. But I do encourage you to take a peek at it. I think there's been a lot of discussion in the recent years about culinary medicine, and for some it may not seem like there's a lot of rigor behind that, but there has been a lot developed to like really highlight what it takes to like understand, culinary medicine. How do you guide patients through, using the knowledge that's necessary to provide them with this health through the food they eat and the food they make. And it's really interesting what some programs have done. So I definitely encourage you all to just explore that, and just to be aware of what exists out there. It doesn't apply to at least our programs here on the north side of the state, but there are residency curricula that exist, and specifically the curriculum that's been endorsed by the American College of Lifestyle Medicine has quite a bit of didactic material that's spread out, but a lot of it actually comes down to these 60 hours of application activities that at the end of, you will have completed everything you need to sit for your certification exam to become a diplomate within the American College of Lifestyle Medicine. But I wanted to talk briefly about what it takes to get certified if you're not in a program that offers this, because it is a significant amount of didactic content that often has to be used for other purposes. So I wanted to put this on your radar, and if you want to just remember the slide for later, or at least remember to check out the website about this. There are pretty clear and easy, pathways for you all to become certified after residency. The most important part, though, is just making sure that, when you're negotiating for your first contract, looking at your CME time and your CME money, to really consider, some of the investments that it does take. Because as you can see, it's, there, like the exam itself is not too cheap. But then again, I think a lot of us in healthcare are very much used to paying for exams like that. So, um, the biggest thing though is that they do have it built into where once you've joined the college, you can get set up with the board review course, which will cover a lot of the CME component. That and then with the conference that happens in the fall every year, those together can complete the CME that you require in order to be eligible to sit for the exam, which is usually right toward the end of the year and very intentionally set up that way so that you have a clear path all the way through from reviewing the materials, attending the conference, and then taking your exam and becoming certified. They're much like the American Academy of Family Physicians. There's also you're also eligible as a diplomate to become a fellow of the college, which is something that you could also explore afterwards. But the most important part is that you get these skills ahead of time, have a formalized, title to kind of, hang that on. But most importantly, to deliver, all of this care to your patients. I mean, that at the end of the day, that's what really matters, not the titles, not any of these certifications, but the fact that you now have the skills to really provide that again as a first line modality. So again, this other slide is just to kind of summarize what we were talking about there. We do have the conference coming up in Orlando pretty soon. There's always the virtual option as well, but just something for you all to keep on your radars, if not for this year, but maybe for future years there. Okay, so we're almost done here. I just wanted to also point out some of the strategic plans for the future from the ACLM. A lot of what they're really, pushing forward now is that it's still, there's still some challenges around payment when it comes to, when you bill for your services and, in these lifestyle medicine modalities, which is why, honestly, that's why adoption's been a little, has been lagging behind because there are a lot of people who agree and feel passionate about all of these topics, but it's just a matter of like making it practical to where you can keep the lights on, keep the doors open to your clinic, wherever you may have your practice. But some of that is also about channeling money into, research efforts to show these very, really well proven benefits of a lot of these modalities, but just to make it unmistakable where insurance companies will have less of a chance to deny payment, or at least, to give you a hard time for certain codes. Um, Expanding their educational offerings. As you kind of, if you get on the website and really explore it, that it has grown so much, even since I was a student back in Oklahoma, where I was introduced to this for the first time. And there are a lot of things that remind me of the educational resources we have through like STFM and other family medicine organizations. So it's really, really interesting. So some of these contents that seen today have actually been directly from those resources as a way of helping with a very thorough introduction to this topic. And again, they really like I will tell you personally, now that I've been on the discussion boards and everything, there are some diehard, very committed people out there in the community who are willing to share resources, assessment tools for all the things that we've covered today related to lifestyle medicine. It's a really, really robust community out there. All right. So we're coming up to the end. Here are the key takeaways that I just wanted to leave you all with as we wrap up, and then we hop into Q&A. So start off, unhealthy lifestyle is a major determinant of health, which is attributable to the majority of morbidity and mortality in the United States. Lifestyle medicine applies evidence-based, whole person, prescriptive lifestyle change to treat and, when used intensively, reverse diseases. Most modern medical interventions for chronic lifestyle-related diseases can merely stall the progression of disease, much like we talked about earlier with the case of diabetes. The evidence-based supporting lifestyle medicine modalities across all 6 pillars is robust and growing every single day. And I might note, might be somewhere that if there was interest from anyone in the group, could be something that, we could actually actively contribute to here in northern New Mexico. Lifestyle medicine modalities have the advantage of high benefit with little to no risk. And most importantly, you can become certified in lifestyle medicine as a healthcare professional, and use these skills formally throughout the rest of your practice. So these other slides are just references in case anybody wanted to look through them later, just so that way you kind of know where all this information was coming from. But all this information can be found in these articles here and resources. All right, so that's everything we have. But if you all have any questions, comments, anything you'd like to talk about, we're open to receiving that now.
All right, any questions? If not, I will go ahead and get us started. Dr. Duncan and Dr. Lynn, thank you for that great presentation. But in terms of treatment, and especially in rural areas, we often see food deserts. So how do food deserts impact how you approach maybe developing a plan for patients?
Let's see here. Alex, if you're okay with that, I'll jump in first with a comment. This was something, this is a really important question because you're absolutely right. We deal with many food deserts here in New Mexico that I think stand out more than they might in other parts of the country. I think the most important part of approaching the conversation of food with your patients is to understand, where they're getting their food from, what it looks like, to be at their home, and being very, I think exercising, like I know it's been a buzzword in medical education, but very truly like exercising cultural humility and knowing that you can't rightfully understand like the many different cultures we have here in New Mexico just by, coming across a patient for the first time. So I think that's a starting point. It's never, I don't think it's ever really beneficial to just give blanket, to give blanket recommendations that for someone who can't access certain food items. And a lot of times it's, working within the framework of what they already have access to, which is something I've been doing more and more here in Espanola. Because sometimes, what our goals can be are to just be mindful of what certain food items contribute to our health, what they don't contribute, and how people can still, enjoy what's very culturally necessary for them, without just kind of, being, overly restrictive with what they're eating. But Dr. Lynn, do you have any other thoughts on that one?
It, I do. One thing that's come up in my studies of food deserts is that attempting to correct them from more of a top-down perspective has not shown a lot of evidence. As we've added, better access to foods, there is a strong preference towards what we're actually um, previously acclimated to. So they actually continue to outcompete as you add and try to address those food deserts, and so much so that they get pushed out again. Um, I that doesn't make the job any easier. Additionally, to that point, there are a lot of healthy options. My colleague, Dr. Diaz Morphine, she has explored Dollar Tree, and they are carrying frozen vegetables. They are carrying canned beans. These are cheap alternatives that will last a long time. Ultimately, the kind of model that I usually adopt is kind of a swaps. What are you feeling most guilty about eating? What do you know is bad? What do I have in my toolkit to be able to swap out from that? And it's a case by case basis to find out, but it's a challenge.
Definitely. And just to add on one last comment to what Dr. Lynn said, because I agree completely. I want to kind of issue a challenge to everyone who's, listening in right now, that one of the best things you can do is after clinic one day or even on a day off, go to these stores and look, because kind of like Dr. Lynn said, once you see what people have access to, you can much more appropriately see that. And that was something I did as a student, when I first started in Tulsa. And it's eye-opening. Like, it makes it immediately clear what you can talk about. And, you may be surprised by what options people do have available. You may just assume that they may not have access to food items that are, quote unquote healthy at all, but oftentimes you can find things and you can work with people within that context. So just a little, for anybody who wants to take up the mantle and accept that challenge, I really think it can really change your practice if you just go and see where people are shopping and getting their food from.
Thank you. All right, we have time for maybe one or two more questions. Does anybody have a question they'd like to ask?
We have a question. Um, about the training for lifestyle modification. And then can you hear her? Can you hear me? Walk up a little bit closer to the laptop.
Yeah, if you're picking up a little bit more.
Hi, I'm Yvonne. So about the training that you mentioned, so after the training, do you think the difference between the one that does the training and the one that doesn't, do you think that the difference will be that they will be able to start like a meal plan for patients, or comparison with a dietitian? How do you think will be worth it, like to do the training? Are we gonna be able to like complete a meal plan for a patient? Is that the purpose of that, or? What are your thoughts about that? Thanks.
I can go ahead. I would say, having attended much of the criteria for American College of Lifestyle Medicine, I would say it is just too comprehensive. If you want to dig down and make that your priority, for the meal plan, which I think it should be, it does require stepping out and making yourself more comfortable with both cooking, which I've been trying to do, as well as shopping. So I feel like we have the opportunity down at UNM. I'm currently, along with my colleague, participating in the culinary medicine um, uh, rotation, which has felt far closer to getting me to the ability of building out that meal plan. There are additionally other resources to kind of provide patients with large lists of healthier foods that they might not be as experienced with. But yeah, no, it's a large field. Cooking is hugely cultural, and people have spent dozens of years trying to perfect the things that they want, and try to convince people to eat things that are healthier for them. So um, you will be very well backgrounded in the information to be able to talk to your patients about how to make healthier choices, the benefits they may experience, and but it building a meal plan is a sub portion of that, and but something that I think you should definitely investigate on your own.
Yeah. And not much to add from there. I think one thing that was very appealing about, getting started on this certification journey with lifestyle medicine was, that it reminded me a lot of training in public health, where it is just so vast. But that's what's kind of, nice about the opportunity to get formal training in it, is that it exposes you to all of these fields and allows you to identify kind of what you want to do. I would, say too, that, I mean, that's a lot like what we experience in family medicine residency too. You're exposed to so many settings of care, all ages, procedural care, other types of care, and you ultimately decide on kind of where your interests lie and what you're comfortable doing in the future, which is, kind of, hand in hand with that point of, once you get that foundation, you can start to build a house on top of it.
I have a question about the state food assistance, food stamps or whatever it's called here. Um, how is it set up for underserved, poor individuals to use in the markets and in the farmers markets? Because our farmers market here is actually a little bit pricey, actually exorbitantly pricey. Whereas in Detroit, we had the Eastern Market, which was a massive farmers market where they could go and buy groceries with what we call the bridge card, which is the food stamp electronic card. So how is it set up in the state in terms of their ability to use it?
Hmm.
Does anyone know?
In
Yeah.
most of our counties, food stamp dollars count as like $1 is $2 at the farmers market.
Yeah, I had heard before, and I don't know, like for example, there in Santa Fe, if we're still doing it, but I know there for a while there was a voucher program where beyond like your government benefits, you could also be eligible for just with a prescription, like they do the food prescription, and I think it allowed for some money, but I'd have to look at that again to see. And unfortunately, I'm a little less familiar with how the benefits translate to other parts of the state beyond Santa Fe.
That's a big thing, is access to healthy produce. That was a massive issue in Detroit because there were no grocery stores, big grocery chains, until recent years when regentrification has occurred in the city. So they would go down to the Eastern Market to get produce, and every merchant there now takes the bridge card. But yeah, it's kind of an important access for people who are underserved.
Yeah, definitely agree. And I think it's a way for us to, make better recommendations and get people that access for sure. Yeah. All right, everyone. It looks like, yeah, we're at 1:32, is just a little bit over. We do appreciate your time, and all of your questions and comments today. Hopefully you found this helpful. Just like Mario said, you'll be able to find this available online later if you'd like to go back and look at the presentation again, share it, whatever it is that you'd like to do.
Once again, thank you, Dr. Duncan. Thank you, Dr. Lin, for that great presentation. And with that said, thank you all for attending today and have a great rest of your day.